our next speaker, so we're moving on now to our next theme, which is Applied Child Health Informatics. It's a pleasure to welcome Professor Andrew Taylor. Andrew is an expert in cardiovascular imaging based at Great Ormond Street Hospital and at UCL. He recently became the new lead of the Applied Child Health Informatics team, and he will take you through this. Thank you.
Thank you very much, Laura. So yes, I have taken over from Neil Sabir, who really this theme was his brainchild. So thank you very much, Neil. But I'd also really very much like to say thank you to Lola and Pia, the deputy co-leads, Dowda, taking pictures today, who's great and keeps us all on track, but also clearly the junior faculty. And also to Thomas and you as a BRC family for being so welcoming as I've come in from April. So that has been great. What have I done with the control now? Oh, there it is. So actually, I'm not going to talk much about the theme because there's many, many things that are shared, but fundamentally we've got three pillars. The first is about how we build infrastructure for data. And what the theme's really about is how we use that plethora of patient data that we've got in a safe and ethical way, but fundamentally for patient benefit, for clinician benefit, and for researcher benefit. And so building that infrastructure, so as ever, a few acronyms here, I'll explain them. So DRIVE is our Data Research, Innovation and Virtual Environment unit, which we have at GOSH. And within that, we have what we call our digital research environment, which is now the term people use, I think, is secure data environment. But that enables us to have de-identified data for secondary use. So that's really, really important. The second pillar is actually how we use data for some of the digital technologies that we have, and Elliot, who's from Oxford University, will talk about that. And the third bit then is really about how we use these huge data sets that we've got, not only with Great Ormond Street data, but with data that we've got nationally to understand what is happening to our patients, our families, and the children across the UK. And Julia is going to talk a little bit about that. As with all the other themes, we link across or we're trying to link across all the other themes around how we use data, but clearly also with bioinformatics across UCL and more broadly across all the BRCs. I'm going to change tack now, so I'm going to talk about a very, very specific example, which hopefully will just give you as a sort of use case of what we're trying to do, what we've done, and I guess as we move forward, potentially into the next BRC, how we might look at AI. So I'm going to be as sloppy as everybody else, and I'm going to use it in a very generic term. And particularly in the next slide, I'll show you something which has got machine learning on it. Just think of it as a form of AI, and we've already heard about computer vision today. So this is actually a slide from Google. So the bit that we all talk about and we think is really sexy is that tiny little red box, okay? That's what everybody, when we talk about ChatGPT, when we talk about all these AI algorithms, that's what we talk about. But if we want to make these things work, particularly clinically, we've got to do a lot more. The first bit, and that's what we've done so far in the ACHI theme, is how you get the data together, so the informatics. The next bit, though, is how on earth do you make sure you deploy these things in a safe way that's responsible and actually does the things that it says it's going to do on the box. So I'm going to take a use case that we've had, that we've developed over about 2 years. And the problem that we identified is, if you take electronic patient records in hospitals, so as a clinician, when I open the record, it's great. Everything is in one place. I'm not hunting for paper notes that might be stored 2 miles away. Everything is there, so I can see everything. As a researcher, also super good. I get the data in one place, and I can get structured data that I can then use for my research. As the person that enters the data into these systems, oh my God, it's just tedious. And actually, there's lots and lots of evidence that you actually get clinician burnout. If you work in the US, you have an AI scribe, usually a medical student, sits in your outpatient clinic, takes your notes for you. Well, you don't quite have the luxury to do that. So what we thought is, can you create a digital AI scribe? So we used a technology working with a small UK startup. So we started this 2 years ago. There were 2 options for us 2 years ago. There are now 134 companies that do this anyway. So we started really to see, actually, could we do this? Could we listen to a conversation in an outpatient clinic and then have a clinic letter instantaneously available at the end of it? So really that's also to try and solve that problem. Whenever we go to our GP now, we're sitting often looking at their back as they type into a thing. Wouldn't it be lovely? Actually, we just talked to somebody. It was all recorded and instantaneously came out. So Our first phase is to build a minimum viable product. We did that within the DRE because we can take data from Epic, de-identify it, and work to build this product. The second phase was we worked with actors. So they were the patients. We gave them a script and real clinicians at GOSH. So we did 48 of these encounters. So you might talk about Star Wars for 20 minutes. I don't need 20 minutes in the letter. I just need like Star Wars. If in the middle of your Star Wars conversation you say, I'm allergic to penicillin, I'd really like to pick that up. So that's the sorts of things that we began to test. And then we did a phase 3 study where we looked at this in 200 patients from Great Ormond Street with clinicians and showed some of the benefits. So you get to the end of this and actually you've then got something that works in children. Okay, can we make it work across the piece? So we, about 18 months ago, approached NHS England London and said, could we do this now in adults, in mental health care, in general practice, in A&E, for London Ambulance Service, so on and so forth. So we set out to do 5 centres with 5,000 encounters, which we've just completed on time and budget. We've done 8 sites and 17,000 encounters. And we've shown some benefits. So the note quality is better. We spent a lot of money on Epic, but now if you actually use something like this, you get better note quality. It's faster. You might be able to see some more patients. Ooh, that might be dodgy because then is that more burnout for people? Might not like that. Well, I'll come to that in a second. It's kinder. You talk to the patient. This is much better. It's safer. Data's entered into the right place. And really interestingly, there's this sort of knock-on effect. We want clinicians to use electronic patient records. It can sometimes be teased, but actually we see a real increase in the amount of clinicians that are using it. But what did we see? Well, we saw that the time that you have as direct care is up by 1/4. A reduction in the time for the appointment. So that you could use that to actually talk more to your patients, but you could actually potentially see extra patients. In A&E, you could definitely see an extra patient a shift. You reduce the admin by 50%. So actually clinicians were coming out going, actually the bit I hate, I no longer have to do. I finish on time, and when I'm at home, I don't have to do the admin work that I was having to do at home, and I go to the pub and meet with my team after work. So actually that burnout bit was really completely changed with this. And then this net promoter thing is, actually am I having burnout? And the answer to that was, it was really helpful for clinicians, and similarly for the patients who really love this. And it got us some good press. So it's just an example really of trying to bring all of that together, how you start off with an idea that's got a very technical research thing, but actually that deployment, that delivery. And I guess for me, the really important thing was we started in one hospital, and within 2 months, we were in and delivering in a new hospital. And that hospital had actually taken on many of the processes that we'd taken forward. So there are 2 talks that we're now going to have. So Elliot, who's a Royal Academy Fellow from Oxford University, is going to talk about measuring oxygenation when patients can't sit still. And that will be followed by Julia, who's one of our ICH PhD students. And that will be primary school trajectories of children with Down syndrome. Elliot.
So my name's Elliot Benteen. That's not a typo. I'm a physicist. I'm possibly a little bit out of my field here. I'm going to be talking today about measuring O2 saturation when patients can't sit still. So we're going to be looking a little bit at the hardware used for O2 saturation. Perfect. Okay, so hands up who here has had an oxygen saturation measurement before. I imagine it's probably everyone. They are ubiquitous. It is more or less the 5th vital sign and used in many different points on patient pathways to make decisions. However, they work very well for adults. They do not work very well for children. And that is because children cannot sit still. You can't necessarily ask them to. They may be having a tantrum as well, so they may be generally inconsolable. And as a result, improving these devices is one of the sort of themes that runs throughout the top 10 priorities for pediatric emergency medicine. If we can't take O2 saturation measurements of children, we can't decide what level of care they need, and we can't triage them appropriately. And that means that we tend to over-refer them, and that wastes NHS resources in the process on people who don't necessarily need it. So first I have to talk a little bit about how these devices work so that we can understand why motion is such a problem and how we hope we can fix it. So the way these devices work, you can see a schematic on the left panel here. We shine light through our fingertip. And what we want to do is have this light interact with the blood and look at how this light is absorbed so that we can measure some property of the blood. But the problem is there are other things in the way as well. So there's bone, there's skin, there's fat. And we need a way to distinguish the signal due to blood absorption from everything else. And to do that, we take advantage of something called the pulsatile wave. So what happens is when your heart beats, it sends a pressure wave down your arm. And this pressure wave causes the volume of the blood in your fingertip to change very slightly. And by measuring the intensity of light shining through your fingertip, you can see this volume change causing little dips in the amount of light that passes through. And we know that the amplitude of that dip tells us about the properties of the blood in the fingertip. So why is motion a problem? Well, in the left panel, you can see a sort of ideal best case scenario trace. So we have this repeated pattern of dips that occur. And in order to take a measurement of these dips, we need to wait for a number of these dips to pass. So maybe typically 10 of these dips to pass. And the problem is this is set by what your heart rate is, and that's typically about a second. And that means we need the patient to be stationary for around 10 seconds to complete the measurement. On the right panel, you can see what happens when the patient starts squirming. So these spikes you can see are what's typically referred to as a motion artifact. And you can see it more or less scrambles the signal so that we cannot actually detect these peaks cleanly. Now, when this happens, we have to start the measurement again. And you can imagine that this is particularly a problem if you're trying to take a measurement from a toddler. It is sometimes impossible to take a measurement from a toddler. It can change a 10-second measurement into a 10-minute measurement, and it can fall outside the time for a GP appointment. So what happens? We don't end up taking an OT SATS measurement, and we end up not being able to decide the best care pathway. So what we're trying to do here in this project is we're trying to wonder, can we make this measurement process faster? If we can make this measurement, say, 100 times faster, then it doesn't necessarily matter if there is motion, because the motion is now effectively 100 times slower, and that's as if the patient isn't moving. But what is the problem? Well, as I mentioned, the peaks occur because of the heart. We can't change the heart rate. That is always going to be 1 second or so. We don't want that to go higher anyway, because that would be indicative of a sort of bad situation for the patient. So we need to find a way to create a sort of artificial signal. And what we do in this project is I want you to pinch your finger like this, and I want you to look at your fingertip under the fingernail. Now, if you squeeze your fingertip, you'll notice that the blood volume under the fingernail changes. And this is what we're going to do in this project. We're going to try and do this very rapidly to see if we can create a sort of artificial heartbeat that we can then measure to determine properties of the blood. So we're using a very simple pager motor. Here it is sitting on someone's thumb. And what we do is we start the pager motor running. And you can see in this trace in the bottom left, so the gray bar is when we turn on the motor. And you can see the red line is our reading, which tells us how much light is passing through the fingertip. Now, at the point where we start this motor running, we begin to see this modulation happens. So by applying pressure that very rapidly changes at your fingertip, we begin to change the amount of blood that's present, and we create a detectable signal that we can use to sort of read out properties of the blood. And the really nice thing is that when we sort of work through the physics of what happens in this system, we find that the amplitude of these oscillations are basically encoded by the pulsatile pressure of the heartbeat. So in the top right, you can see that if we take the amplitude of these signals over time, we recover something that looks like a standard measurement that you would take from a pulse oximeter. But the difference is this isn't a standard measurement. A pulse oximeter is measuring a very slowly varying signal, and because it's slowly varying, fast changes in motion cause that signal to be lost. In this case, we're measuring the amplitude of a very rapid signal, and this signal is much faster than motion, so that even if the motion happens, it doesn't change the shape of the signal that we can collect. And this means that we have a way of measuring the heartbeats in a manner that can be separated easily from the background motion. And so this is a very early stage of this project. We've effectively kind of demonstrated a proof of the principle that we're applying here. I would like to thank my master's student, Noah, who was funded by this SCOSH BRC project. And yes, obviously this is a very kind of early stage of a future pathway to then go and kind of go out and prove that this device works and that we can continue to sort of translate this into healthcare. But yeah, thank you very much for listening. I'd like to pass over now to Julia Shumway, who's the next speaker.
So I'm going to talk about a big data project, specifically primary school trajectories for children with Down syndrome. Right, so this is Amy. She has Down syndrome, and as you can see, she's got her uniform on, she's ready to go to school. When her parents made the choice of what school to send her to, they had two options. They could send her to a mainstream school in her community where the local authority is legally obligated to provide her with appropriate support. Or they could send her to a school that specializes in providing support to children with special education needs and disabilities, also called a special school. So when Amy's parents were making this decision, they actually did not have a lot of evidence to go by. The research is very sparse on which school provides better support for children with Down syndrome, mainstream school or special school. There's also been no national reports letting us know what choices parents of children with Down syndrome make. So we don't know what % of children go to mainstream school and which ones go to special school. That's the objective of this research, to provide some evidence to guide parents and to let them know what kinds of patterns they can expect to see in school enrollment. We did this using what's called the eChild database. The eChild database links state-funded school records to NHS-funded hospital records. It makes it possible for us to follow children in terms of school and health over time. We did this using a cohort that was born from 2003 to 2008. Within those 5 years, there were 3 million children born, and about 3,000 of them had Down syndrome. When we looked at their school trajectories, we found, when we looked at their school trajectories, we found that in year one, which is the first year when schooling is compulsory in England, 2/3 of children with Down syndrome started school in mainstream school. About 1/4 of children with Down syndrome went to special school. And you can see that every year there's about 6% who were not in state-funded schooling. So these children were either home educated or in private schools. That rate is pretty stable. But what's not stable is that ratio between special school and mainstream school. You can see every year more children transfer to special school. So that by the end of primary school, so age 11, fewer than half of children remain in in mainstream school, and only about 1/3 went to mainstream secondary school in year 7, so age 12. All right, so why is this happening? We talked to parents to find out what motivators helped them choose schools, and they listed 3 things. First, they really do want their child to be a part of the local community. They want them to walk down the high street and have people know their names. But they have to take into account the resources available at their local school. And sometimes they have to choose a different school that might be better able to meet their child's learning and physical needs. The third thing they have to consider is school culture. So this can be other children, but for children with Down syndrome, actually children tend to be quite protective of them. It's often teachers and administrators who are either not able or willing to provide adequate support. So when a parent of a child with Down syndrome chooses to send their child to their local mainstream school, they often face an uphill battle. They share stories of spending inordinate amounts of time advocating on their child's behalf. Many parents end up paying for private medical assessments and even legal fees to hold the school and the local authority accountable to provide for their child's needs. This means that there can be a socioeconomic barrier to attending mainstream school where the children of parents who cannot afford the time or money to advocate on their behalf are not able to go to their local school. So in the next bit of this talk, I'll talk about learning needs, physical needs, and social deprivation as predictors of school enrollment. What we found is that all 3 of these play a role in a child's access to mainstream school. So here you can see that children who are assessed by their teachers at age 4 as being more able were more likely to stay in mainstream school. In fact, 75% of children who were assessed as above the group average for children with Down syndrome stayed in mainstream school until they were 11 years old, whereas only 55% of children who were assessed as being below the Down syndrome average stayed in mainstream school. We see a similar picture when we look at chronic health conditions. So children who had more chronic health, fewer chronic health conditions recorded in a hospital setting stayed in mainstream school longer. Those who had more conditions transferred to special school more often. So you might say, great, Julia, the children who need it are transferring to the school that provides more support. This is good. But shouldn't children who have similar learning and physical needs have the same education needs? You would think so, but we still see that socioeconomic status plays a role. So we statistically controlled for learning needs and physical needs. Holding these equal and comparing similar children, we still found that socioeconomic status played a role. In England, children who come from lower income families are eligible to receive free school meals. We found that children who were eligible and received those meals were more likely to transfer to special school sooner. We saw the same thing when we looked at neighborhood levels of deprivation. So this is based on the postcode where a child lives. Children who lived in more deprived postcodes transferred to special schools outside their communities sooner than children who came from more affluent neighborhoods. So now we know. Now we know that socioeconomic status, learning disability, and physical needs all contribute to a child's transfer out of their community. But we still don't know what the long-term effects are of school choice. We need to know whether going to mainstream school or special school has a better long-term outcome in terms of health and in terms of education. And this is the research that's currently being done and made possible using the groundbreaking eChild database. This research is also made possible by the generous contributions of time, data, stories, and cute pictures of children with Down syndrome and their families. And we hope that by doing this research, we will be able to provide them more evidence to help them make choices about their children's education. All right, thank you.
Thank you very much to all three of our speakers. Some really excellent, insightful talks there. If you can all rejoin us. Are there any questions in the room to begin with? Oh, there's one up. Steve.
Thank you for an excellent session, excellent talks. I just want to ask you, Julia, are you doing any linking to look at the effects on the siblings of the children with Down syndrome and psychosocial aspects of the family as well?
That's a fantastic question. Not with this specific study. I think that long-term we probably will need to look into that, but for now it's important to first understand the effects on the child with the condition, and then we can branch out to the rest of their family. But it has been done actually with the eChild network, and so there is potential for that.
Thank you very much.
Thank you. Yes, down on the front here, please.
Hi, yeah, great talks. Again, for Julia, if I might ask, sorry. It's very interesting, you mentioned the 3 measurements in terms of the social deprivation. I just wondered how you detangle the effect of obviously children who are more likely to be on free school meals are also likely to come from a more deprived area. And we frequently see in deprived areas schools having fewer resources. So is there a connection between, can we detangle the 3 different aspects of these things?
Yeah, that is a really good question. It has turned out it's often very difficult actually to disentangle the school's characteristics. There are certain things we can find, like the proportion of children who have special needs at a school, but actually tracking a school over time is quite tricky because they tend to combine or change their codes or academize. So we'd like to, and it's pending figuring out how.
Great, thank you.
I'm going to move to an online question now. Thank you.
Yeah, for Elliot, so you began to touch on this at the end of your presentation, but at the end of your project, what does success look like? What would the next stage look like?
So I think a lot of the sort of current approaches to try and mitigate the effects of motion artifacts tend to work with the existing traces that you get off these devices and find ways of changing how we analyze those traces to remove the noise that way. And this is an idea which is instead to make a very minor hardware modification to the device, which should, in theory, improve the quality of the underlying data substantially. So I hope that because it is quite a light touch hardware change, I mean, obviously it would still have to go through a long pathway of translation and testing and regulatory approval. But I hope that because, you know, a pager motor is not an expensive thing, a piezo is not an expensive thing, I would hope to see that maybe a next generation of these devices could incorporate this technique to make this measurement much more easier and higher quality. Thank you.
Thank you very much. I'm going to ask Andrew a question. Andrew, with the ambient AI technology, does it manage accents well? How is there variability with different accents, different people?
So it does manage accents very well. So we have lots of accents in our clinical teams. It manages those well, and it's been tested across regional accents in the UK. The interesting thing, and I guess the other bit of the question that I often get asked is, does it deal with translation? Translation is a very interesting thing in how you validate it. But actually, so in the GP practice that we were in Northwest London, 40% of the population speak Punjabi. Many of the GPs speak Punjabi. They turned it on, used it in Punjabi, and the results were the same. So I think that looks like that's going to be super important going forward. Now, the only thing I would say about that is clearly in the way that we use this is you as the clinician are still legally responsible for the letter that comes out. So you're the check at the moment in one sense. So particularly if we haven't seen lots of hallucinations, for example, which is this thing where this worry about whether AI makes things up, but we haven't seen lots of those, but fundamentally you're the check. And I would say the one area where it sometimes doesn't quite get it right is particularly if you've got an IMAB with a very long complex name that isn't necessarily picked up, so one of these newer therapies, sometimes those can get misspelt. So those are the sorts of things you've got to check. If you've done a consultation in Punjabi, clearly as a Punjabi speaker, you will then be able to check whether the English has come out correctly for that. So that is something people will have to work on.
Thank you very much. Any more in the room? Sorry, there's one behind you first, then we'll come down to you. Thank you.
Hello, Nick Hodgson from UCL's Media Relations team. Really interesting presentations. Just had a question for Julia. I was wondering when you're looking to publish your research, please, because obviously it's a very hot topic at the moment, isn't it?
Yes. So this piece of research I presented, we are working on getting a draft submitted for peer review. And the piece looking at long-term outcomes is underway in terms of data analysis right now, but that always takes longer than I think it will. So hopefully next year for that piece.
Thank you. Next question in the room here.
So mine is for Andrew. Question on, so Mattia Giarri, Division of Surgery. Question is on reduction of costs. So at the end of the day, yes, it's commendable that you are reducing the workload for physicians and so on. But at the end of the day, what normally happens with the NHS is that if you cut costs and you save time, you see more patients. And there's no impact on the actual life of the physician. So I'm wondering how that is factored in your study.
This is a very good question. So we had somebody do an economic analysis of this, which comes out with a cost saving, but I would agree with you. It's a cost saving that in part is about seeing more people. I think the other bit about the moral distress, maybe too strong a word, but it's not far off, is I think clearly the thing that affects particularly emergency room, our A&E departments, is as clinical teams working in these environments, you don't like having a long waiting list. You don't like a queue that's 6, 7, 8, 9, 10, 12 hours. So if you can cut down on that, I think that will really help. And I guess the bit that we see with all of these is you create a time, to a degree we either as individuals or as a nation can choose what we do with that. So you could see the same number of people and you'd save. But that's not what we want to do at the moment because we've got a backlog. So you can begin, I think, to get into those backlogs. We had this done by somebody separate, completely independent to us. They came out with a number, which is in the publication or within the stuff that we're trying to publish. But I agree with you, it's not easy, is it? How you realize benefit in time saving is a very interesting thing, because what does that mean? That means we have to have a reduction in staff? Is that how we save costs? That's uncomfortable for everyone and probably not the right thing, I would argue, but those are the sorts of difficult questions that benefit realization means that you have to ask.
Thank you. I think we've got another question here.
Yeah, for Julia, please. It's about kind of, obviously the postcode is a really good indicator of economic status, but also have you thought, or perhaps this is like a different study, cultural stigma, immigration status, all those kind of things. And I think on particularly social media, when you see disability, it's not about the money. It's often about how other people treat the people with disabilities, affect their lives in an arguably bigger way than their social economic background.
Yeah, that's a really great question. So there's a few things to consider there. So I will say we have looked at one other measure of socioeconomic deprivation, which was maternal age. So that's more of a social factor, which was quite interesting, but a little more complicated. Um, in terms of ethnicity and language, it gets a bit tricky because in education data, it'll list the primary language at home, but there are quite a few children with Down syndrome who are nonverbal. And we didn't know how that would be recorded. And in order to really use ethnicity data, it's generally best to combine it with that. So we didn't do it for this data set, but we're looking at it for our next piece of work if the language data is reliable.
Thank you very much. I'm going to take one more question. I think Connor has the microphone.
Yeah, thanks, Laura. Connor McCann from Tissue Engineering and Regenerative Medicine. It's a question for Andrew. Presentation was amazing. Obviously, the technology is potentially revolutionary. There's been a lot of mistrust within the public about kind of technological advances, so around digital IDs, for instance, more recently. What's the public's perception about having their health records discussed and then applied by AI?
So in the 17,000 people we investigated, so the first chunk of that, we actually had people in the room. So we consented people for this consultation. And what was interesting is certain people said no, and that was because there were people in the room. In the latter phase of the study, we were recording other things about it. Only one family out of about 15,000 said no. We asked them, and that was the only. Now, that might not be borne out in the future, and I think our advice as we're going through what we would call a phase 5, which is now roll out as business as usual at Great Ormond Street, which will have its ups and downs, but that's what happens with new technology, and we will get there. But I think for me, the thing is, and all of the data that we've got from our YPAG is, and other data that exists from the Health Foundation is, people want to know whether this is being used. I would argue in the future, we'll probably want to know why it's not being used for some of the things, particularly as we move on to decision support over the next 5 to 10 years. And so I think those sorts of things are important. If I look at data, so over the last 20 years, I've collected, had what I would call a generic consent for all of my cardiac MRI patients. And a fundamental question to them would be, would you consent to de-identified imaging data to be used either for research or for education? And 97% of people say yes to that. So my sense as individuals, so in the patient bit of this, is we understand that this is something that's coming, and we know people need to be careful about it, and as ever, we're the trusted people in the clinical setting. There is a difference, there's a slightly different thing about the public discourse, which does worry endlessly about this. There's a subtle difference, and I think particularly in healthcare, provided we're, and it's interesting, so we've just recently done an AI strategy, which we asked a legal firm to look at, and they went, compared to, so if other industries are doing their own AI strategies, the words ethical and responsible aren't really mentioned in those sorts of things, yet that's what our focus is. And I think in that engagement with our patients, our families, and the public, I think that's an important thing that we need to keep on driving through, and there will be ups and downs in this journey.
Thank you very much, Andrew, and thank you again to all three of our speakers.